Welcome to this Faculty for Tomorrow lecture on effective clinical teaching. I am Dr. John Emerson from Prisma Health and the University of South Carolina School of Medicine in Greenville, and my co-presenter is Dr. Tracy Rydel with Stanford University School of Medicine. Effective clinical teaching involves several different components. The overall goal of this learning session is to provide you with evidence-based tools that can improve your ability to work with medical learners. At the conclusion of this session, participants will be able to compare and contrast the differences between teaching learners at the UME and GME level, discuss an evidence-based onboarding strategy for your learner, identify ways to use the preclinical huddle to individualize your teaching, choose and apply a time-saving framework for teaching both within and after the encounter, and appraise different rubrics for learner assessment. Teaching in the outpatient clinical environment presents unique opportunities as well as challenges when it comes to incorporating a learner. A lot of medical education happens in the inpatient environment, and there are some key differences between the inpatient and outpatient settings to consider. We're going to discuss just a few of these. The first is time. The pace of a busy clinic day can limit time for things like prolonged oral presentations and extensive discussions around any specific patient's care. Teaching has to be incorporated in a way that allows care delivery to continue. Knowledge. A family physician may see a broad array of patient concerns on any given day. You may believe that in order to be a successful teacher, you need to be an expert and teach on everything. This can feel daunting. Remember, simple things you may take for granted about your routine clinical day can be great learning opportunities. A genuine interest in the learner and willingness to include them in the care carries great value. And lastly, the impacts on the patient-provider relationship. In your personal clinic, the patients come to see you, not necessarily a trainee that is working with you. Thoughtful selection of the patients your learner sees, as well as outlining expectations for both the learner and the patient, can be helpful. At the end of the day, the goal is to provide the highest quality of care for the patient. One important thing to consider as you are strategizing a plan for working with your learner is their level of training and individual skills and abilities. These will inform your educational strategies, level of oversight and supervision, and the type of support needed by your learner. The way you would approach working with an early third-year medical student is quite different than that of a PGY2 resident. Having gone through your own medical training, you will have some idea about what to expect from a learner at each level. However, if you are fortunate enough to work with a variety of learners at different levels of training, it can be challenging to mentally adjust your expectations. Early on in the teacher-learner relationship, having a discussion to allow for both you and your learner to review expectations and share in the process of developing an educational plan can help prepare both of you for success. One of the most important aspects of working with a learner is to clarify expectations. A great time to do this is during your onboarding with your learner. The 1-Minute Learner, created by Hoffman and colleagues, is a checklist designed to promote discussion between medical students and teaching clinicians about the expectations for the clinical session. Although designed with students in mind, this could also be applied to working with residents with some modifications. This model encourages investment in the educational process by the learner, prompting them to reflect on their goals and helping them feel empowered to gain knowledge of the preceptor's expectations. The clinician and learner can go through this checklist together to create a shared mental model for how they should work in collaboration. After you have developed a shared understanding of expectations around how you will work together with your learner, it's time to get to work organizing your clinical day. We are going to discuss several strategies and concepts to help you in this process of entrusting and tailoring the work for your learner, including how to effectively huddle and triage your session, how to determine the level of autonomy for your learner, and discuss tasks that can help empower your learner to be a meaningful member of the care team.
So the first 4 tips in this manuscript's 12 tips that you can see cited below involve the pre-clinic huddle. We are thinking here about how to set the stage for the rest of the session with our learner, using their learning goals to help guide us in selecting appropriate patients for them to see. It is essential that they work with our MAs or other practice coordinators in clinics so that they can understand the workflow. Before they even head into the patient room, we can remind them of agenda setting. It helps us prioritize our concerns as well as the patient's concerns. If you do use a specific note template for a particular visit, provide that to the learner in advance as well, as many of them may choose to document parts of the encounter during the visit. That is, if they are at a level of training where they can juggle this while still maintaining eye contact with the patient in front of them. The concept of entrustability, well, you're probably already doing this every time you work with a student anyway. So please, don't let the nomenclature of EPAs confuse you. In these cases, you're deciding how much autonomy your learner can have during a visit, both for the H&P as well as components of decision-making or patient education. And the latter would probably apply especially if you're working with a resident, as they can do much more of patient education. You might decide to send a learner into the room independently for just a predetermined period of time, and then you might join them and the patient for the rest of the visit. On the other hand, you might be able to let the student have complete autonomy over their time management and just come get you once they've completed all their tasks with the patient. When it comes to delegation and empowerment, thinking specifically for student learners, it's important to realize that there's a lot that they can do outside of just seeing patients and writing notes in order to contribute to the care team. Delegating responsibilities empowers them, and it allows them to feel like a more vital part of the team. They also tend to have additional time that can allow them to work on some of the things that you might not have time for. There's a few things to consider. You could have them help room patients. This can teach them nursing workflows and help them have a more holistic understanding of the visit. You can have them help with completion of progress notes for the patients that they see. Now, please be sure to share your preferences for how you want your notes constructed or any preferred templates that you use. After visit summaries or other educational materials are crucial. Students can review these in detail with patients. They can help clarify patient questions before they leave, and if needed, they can find additional resources for you that you can have them pass on to patients, like a handout. If you have lab results that need follow-up, under your supervision, students can help review results with patients. They can also assist with immunization administration and blood draw. Our students want to be contributors to the care team, and thoughtfully finding some ways to get them involved can be empowering, and it can give them a more robust educational experience. I'll now pass it over to John, who's going to talk about teaching within and after the encounter.
When working with a learner in the outpatient setting, educators will often rely on their own lived experience to determine their teaching style. Basically, the way you were trained is the way that you will train others. In traditional models, learners often evaluate patients independently, then report back findings to the teaching clinician and share their thoughts on the plan through an oral presentation. The plan may then be discussed and revised before a finalized plan is delivered back to the patient, either with or without the teaching clinician's presence, depending on the level of the learner. There are pros and cons to this model for learners, educators, and for the patients. But an awareness of other strategies to coordinate the education and care delivery may be helpful for a busy clinician. Today, we're going to talk briefly about 3 models: presenting in the presence of patients, the 1-minute preceptor, and snaps, that are evidence-based and can be utilized to maximize your teaching effectiveness. Sharing whichever framework you plan to use with your learner may help enrich the learning experience by engaging the learner in their educational process. The first strategy we're going to discuss is the teaching or precepting in the presence of the patient model, TIP or PIP. In this approach, some component of the encounter, whether it's the history, the physical, or the assessment and plan, are completed by the learner with the attending physician or supervising clinician directly observing. This model has some key benefits. In studies, it increased the amount of face-to-face time between the patient and the attending by 3 minutes and reduced the overall encounter time by 2 minutes. Clinician educators tend to prefer this style of precepting, with learners and patients having a more neutral assessment. A few additional benefits of this model are that it allows direct assessment of specific skills, including the learner's communication style. It also allows you as the content expert to provide simultaneous patient and learner education, which increases your efficiency when providing care. You should be mindful, if using this model, that you need to speak at the level of the patient, avoiding medical jargon or acronyms. The patient should really be the focus of the experience. The 1-minute clinical preceptor model is another well-researched way to organize clinical precepting. The 5 micro skills described in this model are to get a commitment from your learner, probe them for supporting evidence or details, teach a general rule, reinforce what was done right, and finally, correct any mistakes. Getting a commitment seems intuitive, but it can be challenging to maintain patience and hold learners to truly committing to a decision. Committing to a choice puts us at risk of being wrong. Doing your best to create a safe environment where being wrong is okay and normalize that making errors is all part of the learning process can be helpful to make this successful. Probing for supporting evidence can help you understand your learner's clinical reasoning and how they arrived at the answer that they committed to. For general rules, if there's a common finding or rule that relates to the scenario, share that with the learner. This is often informed by what the learner's plan was or the evidence that they provided for their plan. Then reinforce what was done right and clearly provide correction for any mistakes. This model has been shown to be effective in the outpatient clinical setting, though it can take some time to execute it. Lastly, we're going to talk about the SNAPS model. The SNAPS model, developed by Woolpaw and colleagues, is a framework for our learners that really lends itself well to the outpatient clinical setting when evaluating a patient with an undifferentiated problem. In this model, the learner summarizes a brief and pertinent history, then narrows the differential diagnosis to their 2 or 3 most likely possibilities. The learner then analyzes the differential by comparison and contrasting different findings in the history and physical. This provides the preceptor with an understanding of their thought process and clinical reasoning. Yeah. The learner then probes the preceptor regarding any uncertainties that they have and shares their thoughts on an initial evaluation and management plan. Okay. Following this, the learner is empowered to select a topic for their self-directed learning that relates to the case. This model is really owned by the learner, not the preceptor, and it should empower the learner to reflect on their areas for improvement and develop a self-directed plan to close knowledge gaps. Depending on the level of the learner, they may be prepared to discuss the differential diagnosis, but need more guidance for the plan development. More advanced learners should be able to move through this framework fairly quickly and spend more time probing the preceptor regarding their uncertainties and select thoughtful follow-up for self-directed learning topics.
I'll finish us off with discussing issues related to timely assessments of our learners. So many of us have a deadline for how we have to submit our assessments of our learners. For example, the LCME has a strict guideline of 6 weeks or sooner. So we need to be sure to turn in our assessments on time. Now, giving corrective feedback can make some of our kind-hearted preceptors feel a little reluctant to complete their assessments, especially if they feel like something needs correction. So we'll talk about how to use a few frameworks and best practices so that students and residents can grow from our input, and so that you feel confident giving the feedback that they need. The keep, stop, START framework is best intended for giving formative feedback. Formative feedback can be thought of as course correction. It's typically given partway through a rotation, and it may even be given on the fly during a clinic session. Learners respond positively to hearing what went well. So it's important to reinforce what you want them to keep doing. Now, if they're doing something that you would like for them to stop, it's best to frame this feedback as a specific action. That way, it doesn't feel personal, but rather it feels actionable and changeable. Finally, it's always very useful for our learners to hear something that they can try for next time, giving them a technique or behavior to start doing. And that solidifies that they learned something new from the encounter that they had with you. Most of our learners want to hear more than just great job. So using the keep, stop, start method helps with delivering real-time, useful feedback. The RHYME framework is a schema for summarizing our thoughts about a student's overarching or summative performance. Pangara's RHYME framework was initially developed in the inpatient medicine setting all the way back in 1999, but it translates easily to the outpatient setting as well. A learner at the reporter level, they can hear information from the patient, but they don't really synthesize very much, and that learner does not yet recognize what is clinically relevant. This would typically be more representative of a student who is at the shadowing phase of their learning trajectory. An interpreter is able to collate the facts from an H&P, and they can interpret the relevant data and start to formulate a differential and assessment. And this is more typical of your clerkship or third-year medical student level. By the time a learner has advanced to the manager stage, they're devising patient-centered, individualized treatment plans. They're often viewed as the primary provider in a given encounter. Sub-interns are striving to be at this level, and interns and residents should certainly be at this stage. Your educators are able to teach and instruct more junior learners. So many of our PGY2s and beyond, they're entering into this part of their growth trajectory. In thinking about writing up an assessment or giving verbal feedback, it's very important to focus on your learners' actions and behaviors, not personality traits. Unfortunately, there's abundant literature about stereotyped language that might unwittingly be used based on a learner's gender or race and ethnicity. These online guides are very helpful in avoiding more biased language, and thankfully, they offer verbiage that you can substitute in instead. I definitely recommend exploring these websites because they have a lot of practical tips. So what did we learn today? Hopefully, some of your takeaways include evidence-based strategies before the clinic visit to help onboard and include your learners in optimal clinical workflow. During the visit itself, we gave you frameworks and tips for how to manage your time well in a patient-centered fashion and still maintain your goals for teaching and learning. Once the visit or even the entire rotation is completed, how can you get those evaluations and assessments in a timely manner? We hope you enjoyed your takeaways from our session today for the Faculty for Tomorrow Learning series.